Good morning, everybody. Wishing you a nice day. Today we shall talk about the value of EEG in epileptic patient management. Although the interictal EEG recording is neither specific nor 100% sensitive to the diagnosis of epilepsy, it's very helpful in the diagnosis and treatment plans. Regarding the diagnosis, it's important in the differential diagnosis of paroxysmal neurological events. Distinction between the focal and generalized seizure disorders, identification of syndrome-specific changes, recognition of photosensitivity. It is also important in assessing risk for recurrence after single unprovoked seizure, selection of anti-epileptic drugs, likelihood of seizure relapse if medication is withdrawn, identification of epileptogenic region in epilepsy surgery candidates, investigation of cognitive decline, detection of non-convulsive status, monitoring of convulsive status. EEG is the most specific method to define epileptogenic cortex. Its sensitivity and specificity depend on several factors such as age and recording procedures, for example, sleep recording and activation procedures like hyperventilation and photic stimulation. EEG reveals characteristic findings in several epileptic syndromes. Rarely, epileptiform discharges are recorded in healthy, particularly young individuals. Ictal video EEG recording is considered to be critical in localizing the epileptogenic zone. A careful analysis of the first clinical sign and symptom of a seizure and of the evolution of the seizure symptomatology can provide important localizing clues. Although surface EEG recordings are less sensitive than invasive studies, they provide the best overview and therefore the most efficient way to define approximate localization of the epileptogenic zone. Let us dig into the diagnostic value of the EEG in more details. EEG may be helpful in classification of seizure type, especially seizures that occur in certain epileptic syndromes. The syndrome approach remains the backbone of the clinical classification, and the revision of the EEG criteria at these levels needs no particular revision for complete diagnosis. Regarding the etiology, sometimes the EEG is very helpful in supposing structural epilepsy, for example, in the presence of spikes on top of focal slowness. In other times, it can guide the epileptologist for neuroimaging, like in the presence of gross background asymmetry. Several characteristic EEG patterns are associated with well-defined epileptic syndromes. EEG thus helps to define certain epileptic syndromes, which is important for selection of therapy and assessment of prognosis of the epilepsy. One important question is usually raised: can we use the EEG for the anti-epileptic medication selection or follow-up? Actually, interictal EEG has limited use in chronic epilepsy, particularly if well controlled and in remission. In general, treating the EEG is unnecessary, although there is an emerging evidence that suppression of interictal discharges, which cause transient cognitive impairment, may improve scholastic performance in some children. The EEG may reflect unspecific CNS side effects of the standard anti-epileptic drugs, such as carbamazepine, valproate, phenytoin, benzodiazepine, and phenobarb. All standard Anti-epileptic drugs may result in slowing of the dominant rhythm and increase slow activity. Carbamazepine in particular is often associated with apparent deterioration of the background activity, even in the face of the clinical improvement. Less information is available on the newer anti-epileptic drugs. Benzodiazepine and barbiturate result in increased fast activity. Intravenous benzodiazepine and phenytoin result in both acute seizure control and suppression of interictal abnormalities. There is a very close correlation between control of clinically detected seizures and EEG events for patients with absence epilepsy. In some, but not all, patients with other seizure disorders, there is a positive correlation between the number of seizures and the amount of the interictal abnormalities. In studies of children whose epilepsy is in remission, persistent interictal abnormalities have been associated with higher risk of seizure relapse after drug discontinuation. But in adults, the relevance of persistent interictal abnormalities appears to be much less certain. The risk for seizure relapse is increased if the EEG showed slowing prior to medication withdrawal. Every physician must have a goal on requesting EEG, whether this is related to epilepsy or not, as EEG may be indicated in some non-epileptic conditions. Like those. Post-operative routine EEG is a good prognostic instrument for the prediction of long-term seizure outcome following anterior temporal lobe resection. It predicts the recurrence of a single seizure in patients with rare seizures after the surgery. Routine EEG is useful for prognosis at least in three conditions: assisting in epilepsy syndrome classification, predicting recurrence after first seizure, and providing information on seizure relapse after anti-epileptic drug discontinuation. Let us see some cases. This is a 32-year-old patient with left temporal lobe epilepsy due to mesial temporal sclerosis with left F7 sharp wave followed by slow component. This is an 8-year-old child with rare generalized tonic-clonic seizure during sleep that were preceded by left face clonic seizure showing right mid-temporal spikes. This is a patient with migraine without aura, awake, with just eye blink artifact. In a 25-year-old patient with childhood absence epilepsy who had a seizure relapse after being seizure-free off medication for 8 years, the bipolar longitudinal recording demonstrates that a burst of 3 cycles spike wave complexes indicating absence epilepsy. Thank you.